Dr. uh, Dr. Monika Sarkar, she runs the UCSF Women's Liver Program, including a co-located obstetrics and hepatology clinic for patients with liver disease and pregnancy. Her research program also evaluates the role of sex hormones in mast cell progression, including a recently funded oral one focused on hyperandrogenic young women with polycystic ovarian syndrome. She's also first author of the first ASLD guidance document on the management of reproductive health and liver disease. Thanks so much for joining us and giving us this talk today.
Thank you, Raina, and I'm just delighted to be here to discuss my very favorite topic. So I'll try to get through some of these slides a little bit earlier and leave time for questions. So these are my disclosures. So we'll start out with a case of a 33-year-old woman who is in her first pregnancy. So she is at week 25, so in her second trimester. And you are being consulted for abnormal liver tests. So a consult that I get now about twice a month over at Mission Bay. She has an underlying history of hypothyroidism. She's on replacement for that. She is on a prenatal vitamin. As far as her labs go, she has an elevation of her AST and ALT to 70s and 140s. Alk phos is a bit elevated at 150 with a normal bilirubin, and her albumin is on the lower end at 3.5. But you have no available prior data. As far as her CBC, it's completely normal. So we'll talk about this case and ultimately wrap up with her towards the end. But as you're starting to think about how you evaluate abnormal liver tests in pregnancy, it's first important to understand what is normal, what are typical and expected physiologic changes. So when you think about alkaline phosphatase, that is typically going to increase. It's made by the fetal bone. It's also made by the placenta. So we'll oftentimes start to see a rise in the alk phos really towards as we're heading into the second trimester. Albumin, hemoglobin, that typically will go down, and that's related to hemodilutional effects. So there's a really profound increase in circulating blood volume that starts to uptick really as we head into the second trimester. That same effect with some hemodilution can lower your platelet count a bit, but it should not lower it to within a thrombocytopenic range. So if you see a pregnant patient who has low platelets, that's going to warrant additional evaluation. Now, your bilirubin, your AST, your ALT, those measures should not change. So any abnormalities there are going to warrant workup by you. So when we're thinking about liver disease and pregnancy, I like to put it in big categories. So the first being they have known underlying chronic liver disease, or you might be diagnosing their chronic liver disease for the first time. And this is all the stuff that we're accustomed to seeing in our practice. The viral hepatitis, the autoimmune conditions, Budd-Chiari, mast cell, alcohol-related liver disease. The other kind of bucket of entities we have to think about are these acute conditions that are coincident to pregnancy. So they happen to occur when the patient happens to be pregnant. So this is going to be the run-of-the-mill entities that we see outside of the pregnant population, including drug-induced liver injuries, our acute viral hepatitis like Hep A, HSV is something I really think about more commonly in the pregnant population, and especially in immunocompromised populations. I didn't put on this list adenovirus, but we are seeing a rise in adenovirus as a cause of acute liver injury. So more recently, over the past 6 months or so, as we've been seeing patients at Mission Bay, we've been routinely testing for adeno. And then there's other conditions like Budd-Chiari, which can develop new onset during pregnancy. Pregnancy should not cause Budd-Chiari, but it can certainly unmask underlying hypercoagulable conditions. So you might see de novo Budd-Chiari during pregnancy. Likewise, autoimmune hepatitis, I have a couple of patients that I follow who have new onset AIH that occurs in pregnancy. So then, conditions that we'll have to manage into the postpartum period that become chronic entities. And then there's this category of those conditions that are unique to pregnancy. Hyperemesis gravidarum can cause marked rise in liver enzymes, even up to the thousands. That's a very uncommon presentation for abnormal liver tests. The whole hypertensive spectrum, preeclampsia, eclampsia, HELP, even preeclampsia, 20% of these patients can have abnormal liver tests. Intrahepatic cholestasis of pregnancy, and then acute fatty liver of pregnancy, an entity that can progress onto acute liver failure. And then there's the other conditions that we need to know about and know how to manage. So when we're thinking about our cirrhotic patients who get pregnant, those who've had liver transplant or liver lesions. So in the course of this talk, I do not have time to cover all of these, but I wanted to hit on a few conditions that I think are more commonly being encountered in our practice, and especially where we're seeing evolving management strategies. So I'll alert your attention to the guidance document on behalf of the AASLD. This is really exhaustive and covers every possible presentation of abnormal liver tests and chronic liver disease and pregnancy, as well as other reproductive health management like menopausal therapy, hormonal therapy in our patients with liver disease, contraception management. And this is now a few years old, and EASL followed suit last year with their guidance. So in this subsequent slides, we'll talk about also where there is some evolving management since the time that we published the AASLD guidance and how my personal management has changed when it comes to some of these conditions. So this is an overarching roadmap that is derived from the AASLD guidance, and it really is in an exhaustive way trying to show you how to think through abnormal liver tests in pregnancy, going from the left when you have primarily a cholestatic pattern, what are some of the evaluation, the tests that you're supposed to be performing and the conditions you're thinking about. On the right, more of the hepatocellular conditions, and then in the middle, kind of walking you through some of those pregnancy-specific conditions. Truth and reality is that it's going to be a mixed picture, kind of like the initial case that I presented, and you're going to have to use your clinical judgment, the timing when this occurred in the context of their gestational age, some of their concurrent presenting labs and symptoms to help guide you on the most appropriate workup. So I also wanted to spend a moment talking about safe imaging when you're evaluating your patients with liver disease and pregnancy, including what's safe in pregnancy and safe in lactation. And really the key thing here to remember is that the only thing that is contraindicated is MRI with gadolinium. Everything else can be safely done. So usually our first go-to test when we're working up abnormal liver tests is doing an ultrasound with Dopplers. I routinely do Dopplers, again, as I was mentioning earlier, about the possibility of having kind of unmasking of underlying Budd-Chiari. So we'll typically ensure that there's no hepatic vein thrombosis there. Safe in pregnancy, safe in breastfeeding. MRI, as well as MRCP without contrast, is perfectly safe in the context of pregnancy and breastfeeding. But if you do need contrast, a contrast-enhanced cross-sectional imaging, because it's going to change your management during pregnancy, so something where you don't feel that you're able to wait until the postpartum period to get contrast-enhanced imaging, then you can do a CT scan with contrast. And of course, we try to minimize radiation exposure in these moms, but it can safely be performed. So, we will use that card when it's going to really alter how we're going to manage the patient. Okay, so moving on to the first condition that we'll discuss in pregnancy, that being hepatitis B. And we see a lot of patients with chronic hepatitis B here in the Bay Area, as we have a very large Asian population of reproductive age. So we'll start off thinking about a case in this context of a 26-year-old who has perinatally acquired Hep B. She's currently 16 weeks, so earlier on in her second trimester. She's E antigen positive, which is typically what we're seeing with our Asian patients who've acquired Hep B early on, either perinatally or in childhood, who've been raised or born in Asia, and they've had many years to lose, and they'll kind of have this immune tolerant period, and then later on they'll start to lose their E antigen. So her ALT is normal at 18. Her Hep B DNA level is about 10 million. And she is not on any antiviral therapy. So the first question is, how are you going to think about managing her Hep B? Does she actually warrant any kind of treatment at all? So when you're thinking about how to treat a mom for hepatitis B in pregnancy, you really have to first think, does the mom have treatment indications that would mirror the same treatment indications that would be for the non-pregnant population? And that's namely, does she have active disease? So is she having Hep B DNA levels with concurrent liver test elevations that meet standard criteria for treatment? You're thinking about your cutoffs of 2,000 for your Hep B E antigen negative patients, your cutoff of 20,000 for your Hep B E antigen positive patients. Our patients who have first degree relatives with HCC, we like to get them on treatment earlier. And of course, our patients with advanced fibrosis. And if that's not the case, then we have to ask ourselves, does the mom need treatment for the sole indication of decreasing the risk of vertical transmission to the baby? And that is guided by the degree of their Hep B DNA elevation, even in the setting of a normal ALT level. And we know that that threshold is around 200,000. So there's a very negligible risk of a mom transmitting to the baby if her Hep B DNA level is less than 200,000. Now, when we think about when most maternal to child transmission is going to occur, it's nearly exclusively during the peripartum period. And that's with kind of exposure to secretions and blood from the mom. That being said, there's actually no consistent data supporting vaginal delivery over cesarean delivery for lowering that risk. But there is the possibility of the mom transmitting to the baby earlier on. I always tell moms that the risk is not zero, but it's exceedingly rare to kind of have transmission across the placenta. Some situations that can increase that risk are when moms are undergoing some more invasive fetal monitoring or fetal testing, like if the obstetricians are doing chorionic villus sampling, for example, or an amniocentesis. And they are not typically doing any of these procedures unless it is medically indicated. So this is a situation where if I have moms who are going in for this testing earlier on in pregnancy, and in a moment, I'll tell you kind of the timeline for checking in Hep B DNA levels and treating, I might treat them earlier if they have a very high viral load to lower that risk if they're having some of these invasive procedures. And then postpartum risk, we really encourage moms that breastfeeding does not increase the risk of transmitting to the baby. So they should be encouraged to breastfeed if they wish. And breastfeeding is safe to do if a mom is still being treated with either formulation of tenofovir. We'll talk a little bit more about that in the subsequent slide. So as we're thinking about our algorithm for preventing maternal to child transmission, we typically advise testing a Hep B DNA level between weeks 26 to 28. I typically do everything on the earlier end, so I have more time to act to get them on therapy. And so if their Hep B DNA level, we first ask, is it over 200,000? And if the answer is no, you can simply monitor their ALT and Hep B DNA levels every 3 months through about 6 months postpartum. And the risk of flare, having an ALT rise during pregnancy, is about 25%. We'll see that a bit higher in the postpartum period. So that's why we typically like to get a good handle of closer interval monitoring than maybe the traditional every 6 months monitoring that you might do outside of the context of pregnancy. But if their Hep B DNA level is over 200,000, that's when we recommend starting a formulation of tenofovir. You can use TDF or TAF. And that, again, is recommended between weeks 28 to 32. I always start earlier, so I have sufficient time to get that viral load down before she delivers, particularly as we don't know if she's going to have preterm labor, preterm birth, for example. And then once she's on therapy, you can stop at the time of delivery, or you can stop when she just comes in for her routine kind of 3 months postpartum visit. There's no difference in risk of flares. And then after delivery, you're going back to your same algorithm of checking your labs every few months until about 6 months postpartum. All right, so what antiviral therapy is safe in pregnancy? So both formulations of tenofovir, both TDF as well as tenofovir alafenamide, are both safe in pregnancy and have the highest barrier of resistance. So back when we first published the AASLD guidance in 2021, we said we didn't have enough data yet on use of TAF, but really the risks with TDF in the context of pregnancy was potential effects on fetal bone health, because there are risks to bone health in patients on TDF, which we no longer see for patients on TAF, which is why we consider it to be a more favorable agent, in addition to the fact that TAF also doesn't have any effects on renal insufficiency. So at that time, we didn't have enough data. We've since had more patients. I routinely use TAF in the context of pregnancy. I will initiate it if they're not on any agents. And then if a patient's already on TAF, I'll continue it. And then TAF is now supported by the most recent EASL guidance. And so we'll be seeing an update to that, I'm sure, from AASLD in our next iterations of our guidance document. As far as lamivudine and talbivudine, they are safe in pregnancy, but they have a lower barrier of resistance. and we look at data at trajectories of decline in Hep B DNA levels, it is slower. So for that reason, in resource limited settings, these are great to use. That doesn't apply to the majority of us in clinical practice here in the United States. So tenofovir should be your go-to. And entecavir, there's really compelling data in animal studies about harms, but we have insufficient data in humans, so we don't recommend its use. So if anybody is on entecavir, you're going to want to switch them. And that's kind of the take-home point, is that if they meet indications for treatment, start tenofovir. If they're on a different type of agent, you're going to want to transition them to tenofovir. All right, so now transitioning to autoimmune hepatitis in pregnancy. This is something that we also quite commonly see here in our clinical practice. And for this case, we'll talk about a 29-year-old woman with non-cirrhotic AIH. She is on azathioprine at 50 milligrams daily and budesonide 6 milligrams daily. And she's generally been on that regimen for the past couple of years. You did try a brief attempt to lower budesonide 9 months ago or so, and then she had a flare, so she went right back up to her original dose of 6 milligrams daily. She now is interested in pregnancy, but ideally would like to avoid any drug exposure to the fetus. So how are you going to counsel her about control of AIH during pregnancy, some of these medication-related risks, any obstetric risks, or risks for flaring of her disease? So the important piece of data to understand about autoimmune hepatitis is that we really see a shift in how the immune system is functioning over the course of pregnancy. And it's kind of similar to how we think about liver transplant, where your body is trying to avoid rejecting this foreign body that is growing, this graft. And so early on, you have more activity of type 2 T helper cells. And those type 2 T helper cells really have a lot of anti-inflammatory properties. They promote a lot of release of anti-inflammatory cytokines. But that shifts as we traverse through pregnancy, especially as we're getting into the third trimester, end of the third trimester, into the postpartum period. And at that point, we're having kind of an uptick of the activity of type 1 T helper cells, which are much more pro-inflammatory. So this kind of translates into what we see clinically. And what this meta-analysis is showing is that there is a much higher risk of a patient having a flare during gestation, i.e. during pregnancy, as compared to the postpartum period. But flares do occur during pregnancy too, so we can see these in up to 20% of cases, so not uncommon, but it's much more common during the postpartum period. So about 40 to 50% of all of our patients will manifest with a flare, with a rise in their ALT levels, maybe rise in their IgG levels as well, following delivery. But the most important clinical take-home message is that by having remission and control of their disease prior to conception, we can lower many of these risks. So for this first bullet point, we know that gestational flare, or again, pregnancy, flare during pregnancy, is lower in our patients who've had autoimmune disease control for at least 1 year prior to conceiving. Here's some data down below, kind of in these blue boxes, where we know that remission before they conceive is associated with a lower risk of preterm delivery, also associated with a lower risk of a flare postpartum. So very important for moms to understand that they should be maintained on medications that are safe during pregnancy to really optimize their liver health and the health of their babies, and to make sure that they aren't having any untoward risks as far as delivery goes. So what are safe regimens during pregnancy? Well, for those of you in the general GI setting, you probably are very well aware of safe immunosuppression in the context of IBD, which mirrors what we use in the context of autoimmune hepatitis and liver transplant as well. Steroids we readily use. There had been a controversial risk of cleft palate that had been seen on prior studies that have not borne out in more large epidemiologic databases and epidemiologic studies that have been able to dive into kind of individual patient data. So that we routinely recommend for use during pregnancy. Azathioprine 6-MP, as well as calcineurin inhibitors like TAC and cyclosporin, these have been shown to be associated with increased risk of preterm birth, low birth weight, but likely that's related to the underlying condition for which a patient is on these medications, not the actual medications themselves. And so really evolving from the inflammatory bowel disease data, we've seen a lot of favorable safety profiles as far as azathioprine 6-MP. TAC and cyclosporin we routinely use in our patients who are pregnant in the liver transplant context. And then I have a few patients who now have had to have management with these calcineurin inhibitors with autoimmune hepatitis who have more difficult to control disease. So we routinely use both of these agents. The agent that has to be avoided in pregnancy are the mycophenolic acid products, so Myfortic, Cellcept. Highly teratogenic, about nearly a quarter of all babies who are born to moms who are exposed to these agents will have birth defects. So really striking risk. Miscarriage risk is also about 45%. And the types of birth defects are quite broad. There's a wide spectrum affecting ears, limbs, heart, esophagus, kidney. But there's one that's very specific to mycophenolic acid products. You can see with this little boy, he has something called microtia. So this is a defect in the folding of the external ear canal that is very classic for a child that's been exposed to these agents. Now, when you're thinking about what medications are safe in the context of breastfeeding, it's easy to remember because it really follows the same paradigm as what we think about as being safe in the context of pregnancy. We routinely, patients can routinely use steroids, azathioprine 6-MP, calcineurin inhibitors. We do say, and most guidelines will say, to avoid mycophenolic acid products for breastfeeding moms, really given lacking safety data. I will say this one is a bit more challenging for me because the risks of this drug really relate to fetal growth and fetal survival. So it's what's happening during pregnancy, during those gestational weeks, not, you know, in biologically speaking, there shouldn't be any untoward risks after a mom has delivered. So I've actually had a couple of patients who have had liver transplant who have wanted to breastfeed, and we've kept them on their mycophenolic acid products. And there's growing data now from their Transplant Pregnancy Registry International, who is accruing data on moms who are breastfeeding on these agents, so we can kind of glean and get some more safety data. But as you can imagine, there's few because it's very hard for practitioners to feel comfortable with that when most of our guidelines are recommending against it. But in the transplant setting, if we're pulling the trigger to start them on a mycophenolic acid product, it's because their graft really needs it. I also want to just turn your attention to this really great resource called LactMed. It's maintained by the NIH. You can use this for any possible drug exposure, including those unrelated to liver disease. You just type in the name of an agent, and it will give you information about how much of that agent is being metabolized and going into breast milk. It will also give you expert recommendations about the safety of that particular agent breastfeeding. So here for TAC, it says, you know, United States and European experts consider TAC to be probably safe during breastfeeding. And then they'll give you also available existing data and publications regarding these drug exposures. So awesome resource to have whether you are in hepatology or any other field. All right, so when we're thinking about autoimmune hepatitis, I'll also share some data that Connie Wang had published a couple of years ago using something called the National Inpatient Sample Data Set. And this was really relying on ICD codes at the time of delivery. And we were comparing outcomes in moms who had delivered with autoimmune hepatitis. We had just under 1,000. We compared outcomes to moms who had other forms of chronic liver disease. That was about 120,000. And then we also compared outcomes to those who had deliveries with no underlying chronic liver disease. And that was over 18 million patients. And so we were able to really adjust for the most pertinent potential confounders here: age, race, ethnicity, multiple gestation, cirrhosis, underlying pre-existing metabolic disease. And we found that having autoimmune hepatitis was an independent risk factor for preeclampsia, eclampsia, and HELP, gestational diabetes, preterm birth. So here at UCSF, our obstetric team will routinely put any of our patients who have autoimmune hepatitis on aspirin early on in pregnancy to lower their risk of preeclampsia. Fortunately, we didn't see any increased risk of postpartum hemorrhage or maternal or perinatal death. So reassuring data in that regard. What do the guidelines say from our reproductive health guidance? Well, we do advise delaying conception until liver disease is well controlled on stable immunosuppression. As I mentioned, that's really a key clinical pearl when you're thinking about ensuring that a mom's liver is going to be as healthy as possible, as well as outcomes for her baby. At least a year is ideal. We all know that there's other challenges that are posed when it comes to moms who are aging, who have timelines as far as when they can get off work, insurance coverage for IVF, a lot of factors that go into this decision for when they're able to conceive. So it really needs to be shared decision making, with you being able to share the data that we have available for what are the metrics for seeing the best outcomes. We advise liver test monitoring per trimester. As I mentioned, you can still see flares in up to 20% of patients during pregnancy. And then again, even more commonly during that first 6 months postpartum. That's the reason we recommend liver test monitoring every 2 to 4 weeks after delivery. All right, so now transitioning to a more scary entity, cirrhosis in pregnancy. So 36-year-old woman with compensated MASH cirrhosis, portal hypertension. She has splenomegaly, platelets of 120,000. She's never had a prior upper endoscopy. Her MELD score is normal at 8, and she wants to become pregnant. So does she warrant additional evaluation before conceiving? And I'll just say that, I mean, I love that Raina had a chance to introduce me today, because she's had to deal with this now 3 cases, I think, in a short order of like maybe 9 weeks or so of us having these patients who have both decompensated disease as well as compensated alcohol-related cirrhosis, who were managing at Mission Bay and having to bring them in for upper endoscopies and calling on our advanced endoscopists to help with that over at Mission Bay. So we are certainly seeing a rising number of cases. Data here on the left from Ansa Huang, who's over at the VA. She also did a study within the national inpatient sample and showed that the prevalence of cirrhosis in pregnancies has more than doubled since 2007. Over here on the right, you can see even more striking rise, a 7-fold rise in the number of moms who are delivering, who have cirrhosis in pregnancy. And then on this bottom graph, these were when we just took a look at the specific causes of cirrhosis in the Canadian cohort. We found that 3/4 of all of these cases of cirrhosis were actually due to MASLD. So we're certainly seeing a marked rise in both MASLD and alcohol-related liver disease in our reproductive age patients, and it's translating to what we're seeing in our clinic. And Raina had mentioned this co-located OB clinic that I run at Mission Bay. And so we opened this clinic 3 months ago, and our clinic schedule has been packed for all 3 months. And it's almost exclusively us seeing patients with cirrhosis in pregnancy. So something that's really very highly on our radar now. So when we think about maternal mortality, it's more favorable, so less than 2%, whereas, even maybe 10, 15 years ago, we were quoting moms a mortality rate of over 50%. And I think it's really because we have a better handle on managing varices and doing variceal prophylaxis, as that is the most frequent complication. We do know that decompensation events during pregnancy are more common, more likely if you had a prior decompensation. So, less than 2% if you've never had a decompensation versus over 10% risk of having a decompensating episode if you've had a prior one before pregnancy. And then pre-pregnancy MELD of over 10 is a poor predictor for them having higher risk of decompensation during pregnancy as well. So this is an image from our reproductive health guidance, and this is just showing kind of expected physiologic changes. So as I mentioned early on in the talk, we do see a marked increase in circulating blood volume. That particularly happens during the second trimester. There's increase in collateral flow, increase of portal flow, and intravascular resistance around the liver. We also see decrease in systemic vascular resistance just from progesterone levels that are rising in the context of pregnancy. And then there's this kind of compensatory increase in cardiac output. So all of these factors come together to cause exacerbation of portal hypertension. So for patients who already have varices, we can expect that there'll be an increased risk in variceal size over the course of pregnancy. There's also increased risk of ascites and hepatic encephalopathy for patients who have more severe, higher MELD scores, prior decompensation events. But again, varices are really the driver of adverse events in our population. It is associated with about a 20% maternal mortality. Highest risk during second trimester, as I mentioned, with volume expansion. As the uterus is expanding, it's compressing the IVC. We also see that at the time of delivery, and especially with repeated Valsalva maneuvers. That being said, having cirrhosis alone is not an indication for having a cesarean section, over vaginal delivery. So most centers now, especially tertiary care centers, can really shorten the phase of pushing to minimize that. So at UCSF, any of our patients who have underlying cirrhosis in pregnancy will routinely be offered vaginal delivery unless there's some other obstetric indication why they need to have a C-section. Okay, so this was our algorithm from the AASLD guidance about how you think about management of variceal screening prior to pregnancy and during pregnancy. And then I'll tell you how my approach has kind of evolved since we published this. So if a patient has had an upper endoscopy within a year prior to conception and there were no varices, there's nothing more that you need to do in the context of pregnancy. Small varices, we would consider use of a non-selective beta blocker. I always put my patients on a non-selective beta blocker if there's any evidence of small varices. And that's, as I mentioned, we expect worsening portal hypertension as their gestational age progresses. Medium or large varices, it's up to you. You can do non-selective beta blockers or band ligation. You just have to remember that if you're doing band ligation, it means bringing them in until these are obliterated, every 6 weeks or so, which requires involvement of OB anesthesia. It can be quite challenging. If somebody has not had an upper endoscopy within a year prior to conception, in the guidance we are recommending routinely everybody gets scheduled for an upper endoscopy during the second trimester, and then the same algorithm. Small varices, consider non-selective beta blocker, medium or large, beta blockade or banding. Now, you all may be familiar with the use of transient elastography in the general population. So this is a modality that's FDA approved for grading how much scarring you have in the liver, and that's how we routinely use it in our clinical practice. But we now have really robust data that when combined with a platelet count, specifically a platelet count of over 150,000, we can safely exclude those who have clinically significant portal hypertension who already have known cirrhosis. So that's really great because it's helping us in the general population to avoid a lot of unnecessary upper endoscopies. And so now this has been incorporated into our AASLD guidance, the portal hypertension guidelines that came out last year. Now, what you might not know is that transient elastography was approved by the FDA for use in pregnancy in March of 2023. So we're about a year into this. And so my approach in the pregnant population is the same as the non-pregnant population. So if I have a patient who has compensated disease, a normal platelet count, who has not had a prior upper endoscopy, and they have compensated cirrhosis, I am going to start off with a transient elastography. And if they meet these criteria for lower levels, a low liver stiffness and in concert with a normal platelet count, I feel comfortable in my ability to avoid an unnecessary upper endoscopy in that patient. What we do know from existing data on transient elastography in pregnancy is that it can minimally increase the value. So that the value might be inflated, which is okay. And it doesn't do so in a range that typically bumps them from, one fibrosis category to another. But even that minimal increase, just with increased portal blood flow around the liver, is okay by me because I would rather have somebody who I don't want to have anybody that I am falsely missing who has underlying varices. So if I'm pulling more people in for upper endoscopy because, I have a false positive on on a liver stiffness measure, that's okay by me. So the only thing we don't want to do is have false negatives in our pregnant population and subsequent bleeding. Okay, so what non-selective beta blockers are you going to use? In the guidance, we recommend, indicate that it's safe for natalol or propranolol. Propranolol is our favored agent, really because it's very highly protein bound. It has a shorter half-life, smaller amounts are excreted in breast milk. Less data are available on carvedilol, although EASL endorses the use of carvedilol. And as, all of you in the hepatology know, have seen, we've had lots of emerging data on the use of carvedilol in our compensated patients to decrease the risk of progressing onto decompensation. So, we've had a marked rise in prescribing practices and use of carvedilol over this past year. I will typically, I think I put this here. Yeah. So my approach is going to be propranolol first, more because it has less effect on the blood pressure. As I mentioned in one of those earlier physiologic slides, blood pressure does go down in pregnancy. But if a patient has otherwise cardiovascular indications for also needing to be on a beta blocker, I comfortably will use carvedilol in concert with my cardiology colleagues. Okay, so now I think we have the last topic, which is thinking about pregnancy-specific liver diseases. And so we mentioned these kind of early on in the slides, and these are the main conditions that we're thinking about. It's really only 4, although, you know, preeclampsia, eclampsia, HELP is on one spectrum of these hypertensive complications. And the entity that we see the most commonly in our clinical practice is intrahepatic cholestasis of pregnancy. So here you kind of see incidence of preeclampsia being around 8%, but that's not preeclampsia with concurrent elevation of liver tests, which happens about 20% of these 8% of patients. So we'll focus on intrahepatic cholestasis of pregnancy during this presentation. Risk factors are advanced maternal age, multiple gestations, metabolic syndrome. Hep C infection has been tightly linked with ICP, probably because hepatitis C has, it's kind of an irritant or toxin to the biliary epithelium. And so we think that that's why patients with underlying hepatitis C then have a higher risk of going on to get ICP. So traditionally in older guidelines, the recommendation is if any of your patients have ICP, it's recommended that they get hep C testing. That is kind of irrelevant now because you may or may not know that routine hepatitis C screening is recommended for all pregnant individuals, all adults, you know, up until a higher age threshold. So all of our pregnant patients are now routinely screened, not only for hepatitis B but also for hepatitis C. Clinical presentation is itching, and you really want to specifically ask about itching the palms of the hands and the soles of the feet. And other than having excoriations, they should not have a rash. So a rash is, if you do see a rash, that is not consistent with ICP. Diagnosing ICP is the right clinical presentation with concurrent elevation of bile acid. So anything over 10 is abnormal. And I think what really trips people up about ICP is it's called a cholestatic liver disease, but it is a hepatocellular presentation on your labs. So we'll see liver enzymes that can go up into the 500s, 600s, for example. Maternal risks are fortunately quite low. Typically, pruritus, elevated liver tests resolve postpartum. There's nothing more that, that the mother needs to worry about regarding long-term risks. She does have a higher risk of having recurrent ICP for subsequent pregnancies. Genetic variants, those specifically associated with like PFIC, BRIC, can increase the risk for postpartum symptoms and cholestatic liver disease in the future. But it's really the fetal risks that are the scariest for us. It's associated with preterm birth, neonatal respiratory depression, asphyxia, intrauterine fetal demise. That risk is highest with bile acids over 100. Management, the mainstay is URSO, and we have more robust data indicating that URSO is associated with lowering spontaneous preterm birth in babies, especially with bile acids over a 40. So we do routinely counsel moms that URSO can both lower bile acid levels, but also improve outcomes in babies, and it's completely safe. And you can just stop URSO at the time of delivery. I did want to just take a moment to talk about pruritus management because this is going to apply to whoever you see, ICP, your patients who might need pruritus management with general GI conditions. And for our non-medication regimens, just remember we want fragrance-free creams. We like creams, not lotions. You want something that's thicker and going to really protect the skin. Lowering shower temperature, higher temperatures are going to cause more irritation of the skin, loose clothing. But there's a lot of medication options. And I think oftentimes we're under-medicating our patients who have a really terrible quality of life, especially when they're already having difficulty sleeping in pregnancy and now have to deal with pruritus. Ursodiol is not very effective. And I think everybody feels comfortable putting them on ursodiol because it's the most commonly used medication for liver-related indications in pregnancy, but it just doesn't work. So cholestyramine is very effective. You can use this, you know, it doesn't taste great. It's this powder that you're going to have to mix, divided doses. You do need to kind of do a med rec to make sure it's spaced from other meds as it can interfere with some absorption of other medications. SAMe is over the counter. We don't have a lot of robust data on it, but we do have enough data about its safety. That will certainly be what I use after cholestyramine. Antihistamines can be used particularly in the evening, which can help with sleep. And then you can always turn to rifampin, which is safe in pregnancy for patients who have more debilitating symptoms. Okay, so going back to our, oh, sorry, I think somebody might.
Yeah. At 9.
Yeah, I got here early.
Yeah, there's coffee over here. Help yourself.
Jason, I think
Hour just to
you're
get to the
unmuted.
plaza.
Oh my God, huh?
And then there were
Okay,
10
I'm gonna try to talk
police cars as
over
we got
Jason.
towards Treasure Island.
Sorry. Okay.
Okay, perfect. So going back to our initial case, so the 33-year-old who is in her first pregnancy, week 25, recall that she had AST, ALT of 70s, 140s. She does indeed report itching of the palms and the soles. You did a pretty exhaustive workup. Her bile acids were elevated at 60, otherwise had negative serologic testing. Her ultrasound with Doppler looked good, and you were able to get her onto ursodiol. So I typically use 13 mg per kg per day. She did still have really severe itching, so we additionally added cholestyramine, which was helped to control those symptoms. She ultimately delivered at 37 weeks, which is the recommendation when bile acids are around 40. And at delivery, her bile acids had come down to 20 on her ursodiol therapy. Her ALT came down to 40, which is still elevated, remembering normal ALT for women is in the 20. 1 month postpartum, her liver test had completely normalized, as did her bile acids. Her itching had resolved, and her baby was doing well. So I'll stop there, and hopefully we have about 15 minutes or so for questions. And we can also talk about any other liver diseases in pregnancy that I didn't cover today. So any burning questions that you have, this is your time to ask.
It looks like Lisa has a question in the chat. So she said for Ursodiol ICP, is the dosing based on pre-pregnancy or pregnancy weight?
Yeah, that's a great question. I'll typically do it based on their current weight in pregnancy.
Could you speak a little bit to regarding like treatment of like hepatitis C in pregnancy?
Yes. You know what? I might actually just, let me go back to screen. Okay, you can see my screen, right?
Yes.
I wasn't sure. I had a couple just drafted slides. I wasn't sure if I was going to have a lot of time for this. This is a slide from one of my colleagues, Tatiana Kushner, who does a lot of work in the hep C space. So I think the important thing to remember with hepatitis C, we're seeing a lot more of it now, certainly kind of paralleling with the opiate epidemic and a rise in hepatitis C in our reproductive age patients. And now that we're routinely screening all pregnant patients for hepatitis C. And how we have traditionally approached treatment, because it is not FDA approved during pregnancy, is to prioritize capturing our patients pre-conception so we can, get them treated, and then certainly after delivery. And then babies can be treated starting at age 3. We really are having a shift in our approach to this. And I'll share with you the STORK trial. Okay, so STORK is a Gilead-funded study, and this slide was shared by Catherine Chappell, who is the PI. She's an obstetrician, the PI of STORK. And STORK was really using soft valpattosfere, and it was a 12-week treatment during pregnancy. And so these patients would be enrolled at like week 20 to 30, and then they'd undergo their 12 weeks of treatment. And keeping these moms, and many of the sites that have been really successful with STORK, enrolling them have had kind of paired with addiction medicine. So they've had like opiate addiction clinics that have been paired with this, where they've really able to follow these moms throughout treatment. So I will say that what we have that Catherine presented from AASLD in 2023 is, of the existing patients so far, she's had a total that actually completed their 12 weeks of therapy. Everybody has achieved a cure. There have been no adverse risk to the babies. There have been no transmission of hepatitis C to the babies. And then no severe side effects related to this that are drug related. So I think, and this kind of mirrors what we've seen now. We've had growing publications from other countries, including from Egypt, with different regimens. And these regimens mirror many of our HIV therapies that we have long comfortably used in the context of pregnancy. So here, at the county hospital, at the general, they're more comfortable thinking about treatment during pregnancy. Annie Lukemeyer in the infectious disease clinic and Dominika Seidemann readily do this. And then here, I am now routinely talking to all of my patients who are pregnant and offering them treatment during pregnancy. So that is kind of a shift in how we've been approaching it. In the AASLD guidance that we published in 2021, we said, don't have enough data, considering doing it on a case-by-case basis, especially for patients who have like concurrent HIV infection, which does increase the risk of transmitting. Transmission, maternal to child transmission is about like 5-7%. But when you have HIV, it's about double that transmission. So, I think we said encouraged thinking about treatment in pregnancy more if you have like renal disease related to, to underlying hepatitis C, if you have any other kind of extrahepatic manifestations that would benefit from more urgent treatment. But now my approach is I talk and offer every single patient I see with hep C, I offer them treatment. And it's really, especially when we're thinking about our patients who are having ongoing, opiate use and it's a really unique time when they're linked with therapy, and then we lose them. We lose them after delivery. They're not following back up with us. So it's a really special, unique time when we have an opportunity to cure these patients, especially for those that are going to go on to continue intravenous drug use either during pregnancy or after delivery.
Thank you. Yeah, that makes sense. And Omar has a question in the chat as well. Any role for tips in pre-pregnancy?
No. So for our patients, there have been case reports of tips being done, but when we see our patients who have decompensated disease, they certainly have a lower chance of getting pregnant, but they can still get pregnant. We're typically able to manage their diuretics without having to kind of pull the trigger to move on to something like tips. And again, when we're thinking about the biggest risk of death to a mom, it's going to be around varices and variceal bleeding. And we have very manageable ways to handle that do not require something as invasive as a TIPS procedure. Yeah. Oh, it looks like Lisa Dang. How do you think about HCC treatment in pregnancy? Yeah, you know what? Fortunately, I've not had to see an HCC case during pregnancy. I think and how are you going to approach the treatment of HCC? Once and if I see an HCC case, it's really going to be about the timing. Like, how big is the lesion? How far is she along? Is this something we're detecting towards the end of in her third trimester, and we feel comfortable waiting until delivery to kind of manage it? Where that risk really comes up is that we didn't talk a lot about hepatocellular adenomas, but hepatocellular adenomas we commonly see in our pregnant population. So these are lesions that occur in at least about 10% of all patients. We see it more commonly with obesity, prior exposures to any estrogen-containing agent like combined hormonal contraception is a big risk factor. So it's a condition that affects